rettsyndrome.org. I'm Paige Nuez, and on behalf of our board of directors and team, we're so pleased to bring you this entire week of free webinars to help with your understanding and deepen your knowledge of Rett syndrome research and care practices. Your children are incredibly important to us, and having your attention and presence today demonstrates your deep commitment to them as well. We're glad to have you with us. If you're joining us for your first webinar, I'd like to start by going over a few GoToWebinar technical features. The audio feed is open only for our presenter, Dr. Motil, so you don't have to worry about your background noise interfering with the presentation. If you look to the upper right corner of your screen, you'll see a control panel window, and we invite you to write in any questions that you have for Dr. Motil in the question box throughout her presentation, and we'll hold all of the questions and answer them as time allows at the end. If we don't get to your question during today's webinar, we will work with her to get all of your questions answered through email. So please feel free to submit whatever's on your mind on this very important topic. If that control window is distracting to you, you can click on the small orange box with a white arrow to minimize the window, and then you can click on it again to expand it if you wish to submit a question. I also want you to sit back and listen and relax and learn from the information Dr. Motil is presenting today. You don't need to worry about taking notes. We are recording the session, and we will send you a link to the recording afterwards. If you're having any trouble hearing me right now, why don't you go ahead and check your volume controls on your phone or device. And if you're having any technical difficulties seeing the screen or hearing the audio, you can type that into the question box, and myself or Megan Betch will help you troubleshoot that during the presentation. Okay, so with that, I'd like to introduce Dr. Kay Motil. She's an associate professor of pediatrics and a research scientist at the USDA ARS Children's Nutrition Research Center at Baylor College of Medicine, and serves as a pediatric gastroenterologist in the section of pediatric gastroenterology and nutrition at Texas Children's Hospital in Houston. Many of you have met Dr. Motil. She has met many of your children, and we know that we all value her expertise. Very impressed that Dr. Motil earned her MD degree at the Medical College of Pennsylvania and her PhD in nutritional biochemistry and metabolism at MIT. She completed her pediatric residency at Montreal Children's Hospital and her fellowship in pediatric gastroenterology and nutrition at Boston Children's Hospital Medical Center. At Baylor, Dr. Motil's research interests focus on growth and nutrition in children with rare genetic disorders, including and especially Rett syndrome. She's conducted studies on the dietary energy and protein needs, oral, motor, and upper GI dysfunction, and the clinical outcomes of G-tube or gastrostomy placement in girls with Rett syndrome. Her current, many of her projects include the natural history of osteopenia, and she'll be talking about that today, and the role of dietary calcium and vitamin D, and addressing low bone mineral density in our girls and women with Rett syndrome. Dr. Motil has served on the Scientific Advisory Committee for rettsyndrome.org and the National Foundation for Ectodermal Dysplasias and the Pediatric Advisory Committee for the U.S. Food and Drug Administration. She has published over 120 articles in her field, and we are so lucky to have her with us today. And in order to make sure that we have enough time to cover all of her material, I would like us to turn the screen over now to Dr. Motil and let her get started with her talk. Again, if you have any questions for her, please feel free to type them into the question box, and we will field them at the end of her presentation. Dr. Motil, if you'd like to go ahead and accept the invitation to share your screen, I'll let you know when I see your first slide.
My first slide is up.
Okay, not seeing it.
I've clicked the OK box.
Okay. Megan, are you seeing Dr. Motil's slides? Let's see. Megan, are you there?
I can't see them either. Is there another box that came up that you could press?
No.
Can you click on your PowerPoint slide? Or on show my screen, do you have an arrow or do you have the two lines that show pause?
I don't have. Oh, on my screen,
Yeah, the
on
little
the left,
go-to.
lower left corner, I don't have anything that shows anything.
Okay. On the GoToWebinar control panel, under screen sharing, there should be a big circle that says show my screen. Does that have an arrow or does it have two buttons, you know, the two little stripes that for pause? Yeah. There we go.
There we go.
All right, you're ready?
We are ready. Thank you.
Yep, looks great.
Well, good afternoon, everyone. The topic for this webinar this afternoon is common GI issues in Rett syndrome and how to intervene. Now, my problem is I cannot get my slides to advance. Ladies.
If you click on your slide, and then your keyboard control should work again. Just click on it one time.
There we are.
There you go.
So parents frequently have a number of concerns about their daughters who have Rett syndrome, and the concerns that I most often hear include the following. My daughter eats all of the time, but she doesn't gain weight. My daughter screams all of the time. I know something is wrong. My daughter's stomach is full of air. It must hurt. My daughter won't go to the bathroom unless I give her something. I don't want her to become addicted. The point that I want to make about these concerns is that they are not necessarily a Rett thing. Rather, the striking feature about these types of concerns is that they all may relate to motility disturbances of the gastrointestinal tract. My objectives for this presentation are fourfold. By the end of this hour, I hope that you will be able to recognize problems potentially related to GI dysmotility in Rett syndrome, to recognize trigger signs to call your physician, to understand the rationale for selected GI tests, and to understand the approaches to treat GI dysmotility in Rett syndrome. This slide summarizes the types of gastrointestinal problems that we see in Rett syndrome and the frequency with which we see them. Approximately 5 years ago, we conducted a survey with the help of the Rett syndrome organization. Nearly 1,000 families responded to our questionnaire about gastrointestinal problems in Rett syndrome. 92% of all families who responded felt that their daughters had some sort of problem with their gastrointestinal tract. Chewing and swallowing dysfunction was present in 56 and 43% of their daughters. Feeding difficulty was present in 81%. Gastroesophageal reflux was present in 38%. Biliary tract disease was present in 3%. Gas bloating is a common problem, but we do not have data for this particular entity. Constipation was present in 80% of the girls and young women with Rett syndrome. The point of this slide is that every part of the gastrointestinal tract can be affected with gastrointestinal dysmotility, and most individuals with Rett syndrome have problems potentially related to gastrointestinal dysmotility. Now the question is, why do we see gastrointestinal dysmotility in individuals with Rett syndrome? This slide summarizes the results of a very recently published study conducted by scientists at the University of Ottawa, Ontario, Canada. Scientists carefully examined the nerve networks of the gastrointestinal tract, otherwise known as the enteric nervous system, in human and mouse tissues. The scientists found that the MECP2 protein product of the MECP2 gene was found throughout the gastrointestinal tract. It was found specifically in enteric nerve tissues, and it was found throughout the growth and developmental periods of the gastrointestinal tract. The point of these observations is that gastrointestinal dysmotility in Rett syndrome may in fact be mediated directly through primary dysfunction of the enteric nervous system within the gastrointestinal tract, rather than pathways specifically coming from the central nervous system in the brain. Now, I want to focus on some of the specific gastrointestinal problems that we commonly evaluate in girls and young women with Rett syndrome. The first is chewing and swallowing dysfunction. Although parents tell me that their daughters have a good appetite, feeding difficulties occur in about 80% of the girls with Rett syndrome. Feeding problems occur because the neuromotor abnormalities associated with chewing and swallowing occur. Chewing difficulty is defined as poor mastication or the ability to bite into food in a coordinated fashion. Poor tongue lateralization, or the ability to move food from one side of the mouth to the other. Poor food propulsion, or the ability to move food from the front to the back of the back of the mouth. Swallowing dysfunction is defined as pooling of liquids and solids in sinuses adjacent to the separation of the breathing tube from the feeding tube. Penetration of liquids into the larynx, or the beginning portion of the breathing tube, and aspiration of liquids into the tracheal breathing tube. The X-ray on this slide is taken from a swallowing function study. If you follow the white line of barium from the mouth through the pharynx, or the back part of the mouth, you can see the thin white line of barium as it penetrates into the larynx, or the beginning of the breathing tube. This finding is important because it places the child at risk for aspiration. Now, why do we want to treat chewing and swallowing problems? The main reasons are obvious: to control symptoms and to prevent complications. Girls with Rett syndrome who have difficulty eating because of chewing and swallowing difficulty get hungry, and they can be irritable. Conversely, girls with Rett syndrome who have difficulty eating because of chewing and swallowing difficulty get feeding fatigue, and they quit eating because they get tired. The complications of chewing and swallowing difficulties are progressive malnutrition from inadequate dietary intake and aspiration pneumonia from incoordination of the neuromotor function. When parents have concerns about chewing and swallowing problems, I listen for 4 specific issues. Children who take longer than 30 minutes to complete a meal have reduced feeding efficiency. Children who repeatedly cough, choke, or gag with liquids or soft foods have difficulty initiating a swallow. Children who refuse to eat or turn their heads away have feeding fatigue. The effort to eat is more work than they can accomplish. Children who have weight loss or poor weight gain are unable to meet their nutrient needs for normal growth by feeding through the mouth. In this setting, weight loss or poor weight gain is worse during the adolescent growth spurt. Body fat stores disappear and linear growth arrest may occur. Increased activity from repetitive motor movements such as hand clapping does not contribute to poor weight gain or weight loss. And intestinal malabsorption does not contribute to weight loss or poor weight gain. There are 2 diagnostic tests that we use to help us assess chewing and swallowing difficulties. The swallow function study, which was the X-ray shown on the previous slide, is a radiographic study performed with the assistance of a speech pathologist. Chewing and swallowing skills are assessed using thin and thick liquids, soft or pureed foods, and a crunchy cookie. Girls with Rett syndrome typically perform best with thick liquids and soft or pureed foods. The body mass index, the second method, is the gold standard for assessing the nutritional status of an individual. The body mass index is a measure of proportionality between body weight and height. The graph shown on this slide is used to plot and compare the body mass index of girls with Rett syndrome against the body mass index of unaffected girls. For girls with Rett syndrome, a healthy body mass index ranges between the 25th and 75th percentile. A body mass index less than the 5th percentile or below the bottom line should prompt further evaluation or intervention. The treatment approach to chewing and swallowing difficulties per se often is limited. We recommend occupational therapy and speech therapy for assessment and treatment of oral motor function. If oral motor skills tend to wane, they usually wane with advanced age. If oral motor skills are not used, they are lost. Vital Stim is an electrode device that can be applied to the neck in an effort to stimulate muscles associated with swallowing. This device is used primarily in adult stroke victims with reportedly favorable outcomes. At the present time, we do not have data to support or refute the use of this device in children with neurological disabilities, including Rett syndrome. The treatment approach to feeding refusal is the use of alternative feeding methods. In some instances, weight gain can be achieved with the use of oral formula supplements as the primary source of nutrition. When oral formula feeding is unsuccessful, enteral feeding tubes or gastrostomy buttons become necessary. Nasogastric tubes, or tubes that are passed through the nose and into the stomach, may be used to support weight gain for short periods of time. Gastrostomies or gastrojejunectomy tubes require surgical or radiological placement. These modalities are used for long-term treatment of feeding refusal. The indications for the use of alternative feeding methods are threefold. The first is a body mass index less than the 5th percentile or a progressive decline in the body mass index less than the 5th percentile for a period of time more than 6 months. The second is significant chewing and swallowing dysfunction that leads to repeated aspiration pneumonia. And the third is a parent request, particularly in the setting of persistent feeding refusal or difficulty with medication and fluid administration. Gastroesophageal reflux is defined as the involuntary passage of stomach content backwards into the esophagus and the mouth. Stomach content includes acid, digestive, and bile, all of which can injure or inflame the lining of the esophagus. Gastroesophageal reflux is caused by poor motility of the esophagus, the lower esophageal sphincter, or the stomach itself. Dietary, genetic, structural, hormonal, infectious, neurological, or environmental factors may affect esophageal and gastric motility. Why do we treat gastroesophageal reflux? We want to control symptoms and we want to prevent complications. Gastroesophageal reflux feels uncomfortable, it tastes bad, and it interferes with eating and breathing. Untreated gastroesophageal reflux may result in esophagitis or inflammation of the esophagus, ulcers, a stricture or narrowing of the esophagus, aspiration pneumonia, or Barrett's esophagus, which is a change in the lining of the esophagus that may ultimately lead to cancer in later life. When parents have concerns about gastroesophageal reflux, I listen for symptoms such as persistent irritability or screaming for no apparent reason, nighttime awakening with irritability, oftentimes inconsolable, vomiting or regurgitation, wet or dry burps, wheezing, or in fact, frank aspiration. A number of diagnostic tests may be recommended to evaluate gastroesophageal reflux. Frequently, a medical history is sufficient to allow me to make the diagnosis of gastroesophageal reflux. However, the upper gastrointestinal series is an X-ray study that allows us to evaluate the structure and, to a lesser extent, the motility of the gastrointestinal tract. This study is important because it provides assurances that the gastrointestinal tract is in the correct position and that no obstruction occurs. A pH probe study identifies the presence of acid reflux, whereas esophageal manometry identifies the presence of non-acid reflux. An upper endoscopy with biopsies helps us to identify inflammation if it is present in the esophagus. And the gastric emptying scan helps to identify delayed emptying of food from the stomach. The treatment for gastroesophageal reflux is threefold. Dietary modification, positioning, and medication comprise the most important treatments for gastroesophageal reflux. Dietary considerations include the removal of spicy food, chocolate, caffeine, and citrus foods from the diet. Children with reflux should maintain an upright position for 30 minutes after eating, and the head of the bed can be elevated about 45 degrees during sleep. Antacids and histamine or H2 receptor acid blocker medications tend to be less effective and more cumbersome to administer for the treatment of gastroesophageal reflux compared with proton pump inhibitors. Proton pump inhibitors comprise a better treatment choice for reducing acid production in children with neurological disorders who have gastroesophageal reflux. A surgical procedure, the fundoplication, is recommended only when these other medical treatments fail. Biliary tract disease, or more commonly gastrointestinal gallbladder problems, represent three different disorders: cholecystitis, or inflammation in the gallbladder, cholelithiasis, or gallstones, and biliary dyskinesia, or gallbladder dysmotility. We treat biliary tract disease to avoid complications such as hepatitis, which is inflammation in the liver, and pancreatitis, which is inflammation in the pancreas, or the gland that helps with digestion. The frequency of biliary tract disease in Rett syndrome is approximately 3% and is found primarily in older females based on our data from the surveys that families have completed. This frequency that we do observe is similar to the frequency of biliary tract disease in girls with, who do not have Rett syndrome. Although abdominal pain is the usual symptom of biliary tract disease, we always consider an evaluation for biliary tract disease in the presence of irritability or inconsoling screaming in girls with Rett syndrome. The diagnostic tests used to evaluate biliary tract disease include abdominal ultrasound and a HIDA or radionuclide scan. Surgery is the treatment of choice for symptomatic cholecystitis and cholelithiasis, but the treatment of biliary tract disease is less clearly defined. Gas bloating is defined as gastrointestinal gas trapping. Gas bloating appears as abdominal distension that worsens as the day progresses, and the abdomen sounds like a tympanic drum when we tap it. Gas bloat initially is caused by air swallowing in conjunction with hyperventilation, but may result from malabsorptive disorders such as lactose intolerance or celiac disease, infections such as giardiasis, which is a parasite, small bowel bacterial overgrowth, or poorly managed constipation. Why do we treat gas bloating? We want to treat the symptoms and we want to prevent complications. Gas bloating may be associated with discomfort or abdominal pain, but it may be painless. Burping or flatulence produces nitrogen gas from air swallowing, or they can produce methane gas, carbon dioxide, or hydrogen gas from other carbohydrate beverages, sorbitol, which is a non-digestible sugar, or legume consumption. A rare complication of gas bloating is pneumoperitoneum, which is the presence of free air in the abdominal cavity. Pneumoperitoneum is usually caused by a perforation or a hole in the stomach or the intestines. When parents are concerned about gas bloating, I listen for complaints of poor appetite, hyperventilation or rapid breathing with air swallowing, repetitive burping, abdominal distension, irritability, or apparent abdominal pain, flatulence, or diarrhea. A number of diagnostic tests may be recommended to evaluate gas bloating. A blood test may be ordered to evaluate the possibility of celiac disease, which is a dietary intolerance to grains. A stool sample may be tested for the parasite that causes giardiasis or the H. pylori bacteria that causes stomach inflammation and ulcers. An upper endoscopy with biopsies may be performed to confirm the diagnosis of celiac disease. A lactulose or lactose hydrogen breath test may be ordered to evaluate small bowel bacterial overgrowth or lactose intolerance. An abdominal X-ray, such as the one shown on this slide, can be obtained to demonstrate the extent of gas bloating. In this X-ray, the black areas in the bottom half of the body represent significant intestinal distension caused by air. The treatment approach to gas bloating is limited and includes dietary modification and medications. Gas bloating can be reduced by decreasing the amount of carbohydrate beverages consumed or by decreasing the consumption of sorbitol-containing beverages or foods such as prunes. The lactose content of dairy products can be modified by using the lactase enzyme product lactate. A gluten-free diet must be initiated if celiac disease is found. Simethicone is the primary medication used to reduce gas in the intestinal tract, and selected antibiotics, including metronidazole or clindamycin, may help to reduce small bowel bacterial overgrowth, but the results often are temporary, and the medications may be associated with unwanted side effects. The use of laxatives such as polyethylene glycol, milk of magnesia, or senna may be helpful to better control the problem of constipation. Constipation is defined as difficulty with defecation, causing distress and lasting more than 2 weeks. Bowel movements generally are fewer than 2 times per week, and the stools usually are hard, small pebbles, or large balls in size. The cause of constipation may be functional, such as inadequate dietary fiber, structural, such as a tight anal opening, neuromuscular, such as Hirschsprung's disease or muscular dystrophy, endocrine, such as hypothyroid, or drug-induced. Why do we treat constipation? We want to control symptoms and we want to prevent complications. Constipation may be associated with abdominal, rectal, or anal pain, poor appetite, diarrhea from overflowing incontinence, and bleeding. The complications of constipation include anal fissures, fecal impaction, encopresis or soiling, a volvulus, which is an obstruction from twisting of the intestines. When parents are concerned about constipation, I listen for complaints of reduced frequency of bowel movements, fewer than 2 times per week, a change in the consistency of stool, either very hard or very watery, blood in the stool, abdominal distension, discomfort or pain, flatulence, urinary tract infections, feeding refusal, or vomiting. Diagnostic tests that may be performed include a thorough medical history and physical exam, including a rectal exam. A SITS marker study may be obtained to help assess colonic motility. A barium enema is an X-ray study that helps to assess the structure or the anatomy of the colon. Rectal manometry may help to assess the contraction and the relaxation of the rectal muscles at the end of the colon. A rectal biopsy may help to evaluate the presence or absence of nerve cells that assist with colonic motility. A colonoscopy with rectal biopsies help to evaluate the presence of other inflammatory diseases. The treatment approach to constipation is threefold, including dietary modification, medications, and physical activity. Dietary fiber as fruits, vegetables, and cereal is an important first step. Sorbitol, which we've talked about already, is a non-absorbed sugar in prunes and to a lesser extent in pears, and it may be useful as an additive to the diet. Probiotics of choice also may help bowel health. Medications, however, usually are necessary to maintain good bowel habits. Laxatives, both softeners and pushers, may be used alone or in combination. Examples of these types of medications include polyethylene glycol, lactulose, mineral oil, milk of magnesia, or senicides. A newer drug, a chloride channel acting medication, the name of which is lubiprostone, is available for older individuals over 18 years of age. Suppositories such as glycerin or bisacodyl may be necessary as the girls age. Enemas may be required if the stools become impacted. And finally, I want you to be aware of herbal preparations. They may contain compounds that actually are contraindicated in the presence of prolonged QT wave abnormalities. Lastly, physical activity, whether walking, standing, or even physical therapy, are all important to help maintain good bowel habits. For my final comments, I would like to highlight some of the more serious complications of gastrointestinal dysmotility that we are beginning to see. Many years ago, Kathy Hunter aptly coined the term gastrointestinal crises. In this setting, we see individuals who are seriously ill, have abdominal pain and distension, may have vomiting, and generally have a medical emergency that requires surgical intervention. The surgical problems that we see include volvulus, or a twisting of either the intestine or the stomach, intussusception, or sliding of the intestinal tract inside itself, and perforation, or having a hole placed in the stomach or the intestines. The cause of these surgical entities is really not known, but probably has multifactorial reasons. Air swallowing alone does not result in intestinal perforation, but we do know that fecal impaction may be associated with perforation. Volvulus, intussusception, and perforation occur in children across the board. They are not unique to Rett syndrome, but they do raise concern for us in the context of the gastrointestinal motility that we do see in our girls. In summary, gastrointestinal problems commonly found in Rett syndrome include chewing and swallowing difficulties, feeding refusal, gastroesophageal reflux, delayed gastric emptying, bloating, and constipation. These problems are caused by dysmotility of the gastrointestinal tract, presumably because of abnormalities in the enteric nervous system. Any symptom that causes parental concern should be evaluated by a physician. Selected diagnostic tests may be obtained, and treatment strategies should be discussed with your physician to improve symptoms, to avoid complications, and to improve the quality of life of your daughter. With that discussion, I'll close this topic and we'll entertain questions.
Thank you so much, Dr. Montiel. As always, that is one of the most comprehensive presentations I think any of us could ask for regarding GI issues in our children. For our new parents with very young children, I don't want you to be overly concerned that any or all of these issues will be suffered by your child, but I really appreciate having information on hand to know what to do in the event that things do come up, especially with our nonverbal children. We're often interpreting signs and symptoms and trying to triage at home. A lot of parents have submitted questions, and I'm really glad to see that we have about 20 minutes for discussion. So Dr. Montiel, if okay with you, I'll start reading them in order that they've come in, and any that we don't get to today, we'll work with you to do a QA document and send via email afterwards. Okay? So our first question is from a parent who's asking if it's harmful to use liquid glycerin daily to keep their daughter's bowel routine scheduled and predictable, and this is in combination with daily Miralax and liquid calcium magnesium.
The short answer is no. Many times we will in fact use a combination of medications and suppositories to ensure good control of bowel habits. Glycerin is a very benign preparation. It's easy to obtain over the counter. It is safe, and it does not produce harm by simply slipping it into the tail end of the gastrointestinal tract. Most of you know we work very hard to maintain good bowel habits, including avoiding constipation and fecal impaction. And so for me, if suppositories help to ensure predictability and to help remove stool or as I call it, doo-doo from the large bowel, I'm perfectly fine with using suppositories on a daily or less frequently basis, depending on what you need.
Great, thank you. Great advice. Another question along the same line is, if she's only having a bowel movement twice a week, but when she goes, it seems to be formed nicely and not hard or causing any discomfort, should there be any reason to work to change the diet or frequency?
I think that's a judgment call. Obviously, not having seen this particular young lady, I will hedge a bit. But in principle, if your daughter is not uncomfortable, she has bowel movements that are easy, her stools are soft, and they only occur twice a week, I'm okay. I'm assuming she's not distended. I'm assuming she doesn't have hard stools. I'm assuming if her physician were to do a rectal exam, you would not see a rectal vault full of hard stool. Then bowel movements twice a week, soft and without difficulty, are perfectly acceptable.
Great. Thank you. Okay, we're working our way from the bottom to the top. Sorry for the humor. But another question that we have comes from a parent who's, let's see, I have to move my screen here. Okay. So her daughter seems to be twisting and wreathing in pain and pointing to her bottom and scratching at it. And these seem to be spasms that last for almost an hour. And it can happen once a month or more, in spite of emptying every day. And blood and stool tests have indicated everything's normal. Does this give you, are there any ideas that you may have about what could be causing this?
Well, in many ways, let me generalize first and then come back to the specifics. In many ways, the dysmotility that we see in our girls can reflect similarities that we can see in unaffected children when they have nothing more than the irritable bowel spectrum. The irritable bowel spectrum in and of itself is dysmotility of the gastrointestinal tract, usually the lower gastrointestinal tract. And there you can see variations on the theme that run the gamut from constipation to diarrhea to what I call colonic spasm or spastic colon to gas bloating. You can have one or a combination of all of these variations on the theme. So to the degree that girls with Rett syndrome have an underlying neurological disability, they too can have any or all of these types of symptoms. When I see a young lady having what appears to be abdominal discomfort, and at least hearing from a parent that this seems to be low down, I certainly don't dismiss any or all of those particular issues. Stool tests for blood or for other things, depending on what they are, usually don't give us an answer. Oftentimes, these particular tests are done simply to rule out other problems. So when I see a young lady who seems to be having abdominal discomfort and pain, I will not only do the kinds of tests that I presume have been suggested or obtained, but I will very often do other tests to provide assurances that I'm not dealing with other gastrointestinal problems that run the gamut of all the things that I simply talked about in this previous 30 to 40 minutes. I think the fact that a girl will scratch or rub her private parts or in the area thereof, may mean that she simply is having discomfort in that area. Sometimes, of course, we can see the girls rub areas of sensitivity simply because it's part of their responses, their responses that we can see. But I think, we certainly don't dismiss any of these particular complaints until we're certain that we have a better explanation. For those children who do have what I would call part of the irritable bowel spectrum, we certainly do use a combination of medications such as those I've discussed, including laxatives, including gas medications, including antidiarrheal medications. And I think for the issues of spastic colon, if you will, for spasm or for discomfort, there are some antispasmodics that I did not mention in my discussion in the last half hour. And those particular medications are things like dicyclamine or hyoscyamin, which you might think about trying for the spasms of muscles at the lower end of the gastrointestinal tract. So I think that's where I will conclude with those remarks.
Thank you. I appreciate that. I know our parents do too. We have a couple of questions about air swallowing. One from a parent of a child who has a G-tube and one who does not have a G-tube. So let me start with the one without a G-tube. Her daughter swallows a lot of air and constantly has a distended belly, was recently diagnosed with celiac disease, and they'd hoped that by managing that it would decrease the bloating, but it hasn't. And they're afraid that the only solution is a G-tube, but she eats really well, gets a full nutrition orally, and the only reason for a G-tube would possibly be for venting. So is there any concerns you have that other than her discomfort, is there any long-term damage being done by her having a bloated, distended belly long-term?
I think the short answer to that question is we really don't know. I think the longer answer revolves around the whole issue of discomfort. We see many girls who have abdominal distension and walk around just fine, happy as a clam. We see some girls who are obviously in some discomfort from the bloating. I think it becomes very important to think about all the reasons why girls can have tummy distension. And I certainly would think about instituting some of the medical interventions as, if you will, trial by fire, to see if I could make a difference in the amount of distension that the particular young lady might have. So, for example, I'd make sure that we weren't having an issue with the Giardia parasite, particularly in parts of the country where this particular entity is endemic. We here in Texas think about it. I would think about a trial of an antibiotic for small bowel bacterial overgrowth. You could do a hydrogen breath test if you would like to prove or disprove the entity, but in the final analysis, I'm going to try an antibiotic to see if it will help to reduce some of the bloating. Even though this particular treatment approach is temporary, it may provide relief, and although you can't use antibiotics continuously, intermittent trials of antibiotics may be helpful. Certainly, being certain that the management of constipation is in order, that's another area that we have to really pay attention to. In the long run, does air swallowing, significant painful bloating cause problems? I suspect to some degree for some individuals it may contribute to some of these acute abdominal crises that we see or that we can see, but by no means is it a universal outcome. So I don't know whether a gastrostomy is absolutely necessary, nor do I know whether it will be the panacea of treatment modalities. But it certainly is an option, and obviously it's a trial by fire answer that you will have once you commit. Gastrostomies are always reversible if, you know, it's something that the parent does not like as an approach. But obviously it's a significant commitment once that step is taken. So I don't know if I've really answered the question in its totality, and I think that's the kind of decision that has to be made between the parent and the physician based on the discussion that is held at the time. So I think I will close with that remark.
Okay, thank you. And we had a couple of parents write in to kind of to add on that they have that they had G tubes placed to help with the discomfort from their daughter's air swallowing and bloating, and it has been a lifesaver. And
yes, every child is an individual, and parents always tell me, I don't want surgery, I don't want a button, I don't want. And so what really, parents have to feel comfortable with the decisions that they make. I don't think any of us want to push any parent into having a surgical procedure that they don't want. When you come out the other end, you have to know that the choice that you have made for your daughter really puts her in a better place. In general, venting through the gastrostomy button is a favorable outcome. But sometimes it's not always what the parents hope for. Sometimes you still do need to use feral bags. Sometimes we still do have adverse outcomes that may or may not be related to the air swallowing. There are so many unknowns in our girls with Rett syndrome, and there are so many unknowns across the board in general in medicine. And so, again, what we want to do is make the best decision for each child as an individual. And yes, a gastrostomy button may be a tremendous lifesaver, but we also want to be sure that when you make that decision, you make that decision with your eyes open, knowing that you have made all the best decisions for your child. And we want to help you get there. We do this as a group of people, not as one person alone. So I'll end there.
okay, thank you. We have a few more questions on air swallowing. We'll get those and bloating. We'll address them through the QA document, but we have a number of questions about nutrition and diet. So if we kind of switch from the mechanics to the actual nutrition and diet, we had a parent ask about the importance of multivitamins. Her daughter eats by mouth, is a great eater, eats a variety of foods, and they've had trouble finding a multivitamin that's palatable to her. Chewables are hard, gummies are difficult for her. The liquids generally don't taste good. So do you have any suggestions for a good multivitamin to round out what sounds like a pretty good diet already?
Well, there are two issues here. Number one, in reality, multivitamins may not be necessary, particularly when we have a well-balanced, well-rounded diet, and when the girls are growing well and gaining weight normally, and their trajectories on the growth curves are looking pretty good to my eye. The real reason we often focus on multivitamin and mineral supplements is because we are concerned about vitamin D in the diet. We know that at least 20% of a large group of girls with Rett syndrome, from our studies at least, we know that 20% of our girls are deficient in vitamin D. We know vitamin D is important because it helps to facilitate calcium absorption from the gastrointestinal tract, from the diet across the gastrointestinal tract and into bones. We know calcium absorption is important because of bone mineralization. We know that at least 50% of our girls tend to have poor bone mineralization. We know that 30% of our girls tend to have fractures by the time they get into their 20s. We know that our girls oftentimes don't drink sufficient milk, have sufficient cheese in the diet, and milk happens to be one of the major food products that is fortified adequately with vitamin D when drunk in sufficient quantities. So the real issue here is vitamin D in the diet, because many times the girls don't get out into the sunlight. They don't stay outdoors with sufficient timing. My folks who live in the northern part of the country, it is customary for many of the younger children to be supplemented with vitamin D because of the shortened time of daylight. And so the real issue here is vitamin D. Now, you can buy products across the board that have just vitamin D. The capsules are probably not a good idea if your daughter can't swallow. Oftentimes, if you can crush the chewable multivitamins that contain sufficient vitamin D, you can top them in some yogurt or applesauce if your daughter can swallow those two particular entities with reasonable efficiency. If you have to do a liquid vitamin, you can mix it in something that you might be able to mask the flavor. So some of the liquid preparations, for example, if you get the really concentrated vitamins, you can just use drops, but you do have to be careful that you don't over-medicate. If you buy the common pediatric drops that don't taste so well, usually 1 milliliter, if you can bury that in something like mashed potatoes or bury it in something like applesauce, that will go down without too much difficulty. So crushing a multivitamin and trying to mix it into some palatable food source oftentimes gets you by, or again, mixing the liquids in some sort of palatable food source. That too will get you by, or you can mix it in milk, or you can mix it in chocolate milk. That too may vary the taste, or even if you divide up the amount of the supplement across the day, it doesn't have to all be given in one fell swoop, and that too can help accomplish the end result of supplementing your daughter if it's necessary. The recommendation for vitamin D, of course, in the general population is 600 units a day. Most of your vitamin supplements only have 400 units. Some of the companies are increasing the quantity in their products. For our girls, as they get older, we often are interested in doing just a touch more because of the bone issues. The just a touch more translates as 800 to 1,000 units a day. You have to read the labels to be able to determine how much vitamin D your daughter is actually getting. But it is the vitamin D that is the most important factor when we talk about vitamin and mineral supplements. And again, in those individuals who really do truly have a good diet, have good bone health, we are not nearly as pushy about the supplementation. I'll close on that topic.
Okay, great. Thank you. Very important. Okay, I have one general question that might be relevant to a lot of people out there, so let me ask this one, and then I think we'll need to finish our webinar for the day. A parent is asking, her daughter doesn't seem to have any GI issues yet. When do you recommend that a family should go for at least a baseline assessment with a gastroenterologist, join the team, and then do you see a general trend that as girls age, that things like gastric emptying increase and change, that reflux increases with scoliosis onset or other symptoms? Just kind of in general practice, what would be your guideline of when a family should start seeing a gastroenterologist on a regular basis after the diagnosis of Rett syndrome?
I think a family never needs to see a gastroenterologist if there are no issues. I think a good pediatrician who's worth their weight in gold is certainly capable of making or helping to make a decision of the timing with respect to referral to specialty physicians. I think any time parents are concerned, that's the time you have a general discussion with your pediatrician, and if your pediatrician can't or isn't able or you don't think is answering your questions sufficiently, then I think for your own ease of mind and satisfaction, a referral to a gastroenterologist is appropriate and reasonable. It is true that we tend to see gastrointestinal problems more commonly as the girls age. It is true that gastrointestinal problems, particularly constipation, for example, tends to be more problematic as the girls age. Can you still hear me?
We can.
Okay. And so I think that over time, it's not uncommon for families to need the assistance of a specialist. But by no means is a gastroenterologist mandatory the minute you know the diagnosis. And I'll end my discussion at that point.
Thank you. That's a wonderful point to end on. I know we have many, many more questions here, and like I said, we'll work with Dr. Motil to get a question and answer document prepared. Thank you so very much for your time today, Dr. Motil. Thank you to all of our attendees for sticking with us and for attending this session. Take a look at the agenda. That's at rettsyndrome.org, and we have many, many more sessions this week, and we hope you're able to join us for them. We want to thank our sponsors, Tobii Dynavox and Ameripride, for sponsoring these sessions so that people from all over the world could attend at no charge. We do ask, if you could, please take a moment to answer our attendee survey so that we can fine-tune future webinars that we hope to be able to offer to you. I think this is a fantastic platform for learning and getting a chance to meet with our experts and ask the questions that we all face every day. So Thank you very much for attending today. Thank you for letting us record your presentation, Dr. Motil, and we look forward to meeting you in a venue similar to this again. Have a nice day, and we'll see you all at our next webinar later today. Bye-bye.